Hello everyone, this is Dr. Garima, one of the mentors of StudyMEDIC, and today we'll be discussing important concepts on core surgical skill module. So, first of all, the first topic that we will be discussing is about the GTG, preventing injury-related gynecological laparoscopic injuries. So, the technique of laparoscopic entry, either it could be closed or open. Closed, you do it through Peary's needle or a direct trocar insertion. When you insert Peary's needle or direct trocar, you usually hear 2 clicks as the layers of the abdomen are penetrated. Open is also called as Hassen's technique. So these are the 2 techniques and how they are performed. Okay. And usually, in non-obese patients, the angle at which you are inserting the Peary's needle is less than equal to 45 degree. And as the weight increases, the angle keep on increasing. And obese, who is more than 200 pounds, usually you insert the Peary's needle perpendicular. Now, what should be the pressure, intra-abdominal pressure that you should set while inserting the trocars? For primary and secondary trocar insertion, the pressure should be around 20 to 25 millimeter of mercury, and the laparoscopy should be performed, like the entire procedure should be performed at a set pressure of around 12 to 15 millimeter of mercury. Then what are the various laparoscopic entry points? So the most common we all know is the umbilicus. The alternative points are the Palmer's point, which is 3 cm below the left costal margin in the mid-clavicular line. The other points are Li Wang point. So if you join a line between the xiphisternum and the umbilicus, midpoint of it is the Li Wang point. The next topic that we will be discussing is avoiding vascular injuries during laparoscopic gynecological surgeries. So this is one of an important exam tested questions, like what is the safe site for insertion of the secondary ports? So if you can see here, the dark green one and the yellow one are the safe zones. So there is a safe zone where the ports can be inserted with a low likelihood of injuring, because the most common vessel which is likely to be injured while you are inserting the secondary port, for which you have to be cautious, is inferior epigastric artery. And the safe zone where the ports can be inserted with low likelihood of injuring this artery is within 1 centimeter of the midline, and if you take more than 8 centimeter from the midline. Insertion of the ports more than 2/3 along the line joining the midline and ASIS. So if you join the line from midline to ASIS, at a junction of 2/3 and 1/3, we have this yellow Tinelli's island. So again, it is a safe zone. So Tinelli et al. Describes the yellow island, which exerts 1/3 of the way from the ASIS to the umbilicus and can be easily identified in those even with increased BMI. This yellow zone can be used for safe placement of secondary ports. Then, what should be the position of the patient while you are inserting the ports? So ideally, it should be supine position. And why is it so? Because the abdominal aorta bifurcates into the right and the left common iliac arteries at the level of L4. And in supine position, the aortic bifurcation ranges from 5 cm cephalad to 3 cm caudal to the umbilicus. And in the Trendelenburg position, it ranges from 3 cm cephalad to 3 cm caudal. So there is a gap of 2 cm. Aortic bifurcation caudal to umbilicus is seen in 33% of the laparoscopies carried out in Trendelenburg position versus 11% in supine position. This supports insertion of Peary's needle and the first trocar in the supine position before raising the legs into the Trendelenburg position. These findings were not affected by the patient's BMI. The next important topic that we will be discussing is about the peri-umbilical adhesion risk. Again, an important exam tested question. So, if previous surgery, there has been no history of previous surgery, still there is 0.68% risk of peri-umbilical adhesions. If there has been a previous laparoscopic surgery, then the risk is 1.6%. Previous transverse laparotomy, it is 19.8%, and previous midline laparotomy, it is 52%. Then moving on to the next guideline on hysteroscopy, what should be this is again an exam tested question. So in this, the patient is asthmatic and you're planning for hysteroscopy. Ideally, if you have to give an pain relief for analgesic for hysteroscopy, you can either give NSAIDs or paracetamol. But since this patient is asthmatic, you will preferably avoid NSAIDs, and here the preferable option would be paracetamol. So, regarding analgesia requirement for hysteroscopy, routine use of opiate analgesia before outpatient hysteroscopy should ideally be avoided as it may cause adverse effects. And women who do not have any contraindications should be advised to consider taking standard doses of NSAIDs, that is 1 gram paracetamol or 400 mg ibuprofen around 1 hour before the scheduled outpatient hysteroscopy appointment, with the aim of reducing pain in the immediate post-op period. Regarding cervical preparation, routine cervical preparation before outpatient hysteroscopy should not be used in the absence of any evidence of benefit in terms of reduction of pain, rates of failure, or uterine trauma. So, routine cervical preparation is not at all recommended. Moreover, prostaglandins, they are associated with GI side effects and are contraindicated in severe uncontrolled asthma, chronic adrenal failure, acute porphyria, renal or hepatic impairment, and breastfeeding. Regarding cervical dilatation, it is not routinely recommended. Blind cervical dilatation to facilitate insertion of the miniature outpatient hysteroscope is unnecessary in majority of the procedure. Routine cervical dilators are associated with pain, vasovagal reactions, and uterine trauma and should ideally be avoided. Cervical dilatation generally requires administration of local cervical anesthesia. Regarding uterine trauma is recognized with blind and endoscopic instrumentation of the uterus, and the incidence is around 0.002 to 1.7%. And factors which are associated with risk of uterine trauma include blind dilatation, cervical stenosis, tortuous cervical canal, deviated uterine cavity. Then what should be the preferred distension media for outpatient hysteroscopy? So you can use both carbon dioxide and normal saline. However, if you ask, the preferred one, the best one is normal saline. So uterine distension with normal saline, it allows for improved image quality and allows outpatient diagnostic hysteroscopy to be completed more quickly as compared with uterine distension with carbon dioxide. So normal saline is always more preferred than carbon dioxide. So these are the two media, carbon dioxide and normal saline, which are used as distension media. Regarding the episodes of vasovagal episodes, they're lower with normal saline, better image quality with normal saline, quicker procedure with normal saline. However, in terms of pain, none of these is superior. And if you are planning for operative outpatient hysteroscopy and you are planning to use bipolar electrosurgery, then better is normal saline, because then it acts as both distension as well as conducting media. Then again, a very important exam tested question. So when you are using monopolar, then ideally you should not use normal saline or carbon dioxide. Then best distension media in such cases is glycine. But the problem with glycine is it causes fluid retention and causes electrolyte imbalance. So you have to do a strict input-output monitoring while you're using glycine as a distension media. So when you see the fluid, like the deficit is 500 ml, you should ensure that the anesthetist is aware of the deficit. When the fluid deficit is 1 liter, then ideally you should expedite the procedure. Try to do it as fast as possible. You can leave a Foley's in the bladder. Continue monitoring the output and the input. Can consider fluid restriction. Consider IV diuretic like furosemide administration. If it is 1.5 liters, then ideally the procedure should be discontinued. Serum electrolytes and abnormalities should be managed appropriately. You should observe the patient for the signs of fluid overload and encephalopathy, seizure activity, pulmonary edema, and tachypnea. You should admit the patient for observation and management of the complications. Then moving over to the next guideline on electrocautery, how do you manage, what is the difference between electrocautery and electrosurgery? So electrocautery, you use only direct current, while in electrosurgery, you're using alternating current. Electrocautery, there is transfer of heat to the tissue with no current passing through it. Electrosurgery, there is application of high frequency alternating current, and with electrocautery, you can only coagulate. However, with electrosurgery, you can cut, desiccate, coagulate. And this is again an important exam tested question. The frequencies that are used for electrosurgery are generally greater than 500 kilohertz, which are similar to the radio frequency. And the term radio frequency electrosurgery is hence used. And the electrosurgical circuit includes a generator. There are two electrodes and the patient. And all electrosurgery that we use is bipolar because it involves two electrodes. Then again, an important exam tested question. So you have to remember the temperature at which various effects of electrosurgery are elicited. So 37 degree we all know is a normal body temperature. Cell death within 6 minutes occur if the temperature is 50 degree. Instant cell death at 60 degree. At 60 to 95 degree, white coagulation occurs, and cutting or cellular vaporization occurs at 100 degree, and carbonization or black coagulation occurs at 200 degree. Then about the injuries associated with electrosurgery. So there are various patterns of injury. There could be active electrode injury, which could be because of the direct application or inadvertent activation of the electrodes, or because of the residual heat. Or there could be because of insulation failure. And there are three types of coupling, which I'll be briefly discussing now: antenna coupling, direct coupling, and capacitative coupling. Now, what does inadvertent activation mean? What happens that if accidentally you happen to step on the foot pedal and the tip of the electrocautery needle is touching a tissue, it can cause inadvertent burn. A prevention strategy for this is avoid accidentally stepping on the foot pedal. And when the active electrode is not in use, ideally you should remove it from the body and place it in a dry, rigid plastic holder with no other instruments. You should use an audible activation tone to be heard by the team. Now, what is direct coupling? So, direct coupling occurs when the active electrode, it touches another metal instrument such as a suction irrigator or a camera telescope, and the current from the active electrode flows to the second instrument and potentially burns any tissue that touches it. Then what is antenna coupling? This phenomena occurs when active electrode emits electromagnetic energy in the air, which is captured by the nearby inactive cord or wire, which is the receiving antenna. And it may be regarded as a type of capacitative coupling and can result in unintended tissue burns. The receiving antenna may be the camera cord or the wires of the monitoring devices such as electrocardiography or neuromonitoring devices. So for antenna coupling, what is most important is this parallel arrangement. What happens in case there is a parallel arrangement, suppose here in this case, between the electrosurgical unit, light source and camera, this electrosurgical unit will emit certain electromagnetic rays which are captured by the light source and the camera, and when they touch the patient, they will cause the burns, and this is what antenna coupling is. Then there is another type of coupling which is called capacitative coupling. So capacitative coupling is again like antenna coupling, however there is no parallel arrangement. So in this again, what happens, there is transfer of electric current from the active electrode through the intact insulation into the adjacent conductive materials without direct contact. Unlike insulation failure, capacitative coupling may transfer a percentage of the energy to the unintended tissue or adjacent instruments. Now discussing about the urinary tract injuries in the laparoscopic gynecological surgeries, its prevention, recognition and management. So starting with the urinary bladder injury. So like the most common, if they ask you what is the most common structure to be injured in pelvic surgeries, the answer will be bowel. However, amongst the urinary tract, the most common structure to be injured during pelvic surgeries is bladder, with the incidence of around 0.02% to 8.3%, and most of these injuries occur during when you dissect the bladder from the cervix. And the most common site for this is the midline, which is above the interureteric bar. And only 50% of these bladder injuries, they are recognized intra-op. That means the remaining 50%, they are missed during the intra-op period and recognized in the post-op. And the risk factors for the urinary tract injury include endometriosis, cancer, adhesions, severe genital organ prolapse, obesity, or pregnant moms. How do you treat these patients? You refer these patients, either the management could be by the gynecologist or a urologist. However, if they ask you particularly if they are involving the ureters or if they are involving the trigon, it is better that you involve the urologist in this. The suturing should be done in 1 or 2 layers using a 2O or 3O absorbable suture. It should be a running, non-locked repair with the sutures placed 0.5 to 1 cm apart and 0.5 to 1 cm lateral to the cystotomy angles. Then the injuries which involve the trigon, ideally ureteral stents must be inserted and patency of the urethra and the ureters should be confirmed following the repair. The repair should be watertight and the leakage from the suture line should be tested. And the bladder catheter must be inserted and continuous post-op bladder drainage should be advised for 2 weeks. And even like after 2 weeks, if you're planning for the catheter removal, first you should do retrograde cystography to see the repair is adequate, and then only you remove the catheter. In case you feel that there is still a leak, better place the catheter for another week and do a retrograde cystography again. Then coming over to the next, which is the ureteric injury. The incidence of ureteric injury is either like it ranges from less than 1 to 2%. However, if you are doing it for deep infiltrating endometriosis where you feel that everything will be stuck and the adhesions will be there, the incidence is quite high, around 21%. The most common site for it is at the pelvic brim and lateral to the cervix. And only 33% of the ureteric injuries, they are recognized intraoperatively, and most common type of ureteric injury is transaction. So these are the various types of ureteric injury. Either it could be angulation, crush injuries, ligation, thermal injuries, laceration, transection, resection. How do you repair these? So if it is basically, the concept is about the site specific repair. If it is involving the upper third of the ureter, you do ureterostomy, end to end re-anastomosis of the ureter. If it is middle third, you do ureterostomy or transureterostomy. If it is at lower third, you do ureteroneocystostomy, psoas hitch or Boary's flap. In case there are minor crush or needle injuries, they are managed conservatively provided that the ureter's integrity and viability have not been compromised. That is, there is peristalsis and adequate perfusion present with no leak. In case there is obstruction, it is best managed with ureteral stenting. And thermal injuries, stenting should be done to prevent stenosis and urine leakage during healing. What are the principles of the ureteric repair? Ideally, the repair should be adequate, but careful debridement should be done in order to make sure that you're not shortening the ureter. Okay, you should try to preserve as much healthy ureter as possible. And careful dissection should be done to avoid devascularization, and the anastomosis should be watertight, tension-free, spatulated or Fishman. So this was all about the management of the ureteric and the bladder injury. I hope it is clear. Thank you so much.